Dr. Meredith McKean has been with Tennessee Oncology for 4 years now, Meredith, 4 years. But she's one of my favorite people to reach out to when I have a question, far smarter than I am, thank goodness. But is going to join us to help us understand the melanoma environment right now. Thank you, Meredith.
Great, good morning, and I also would like to thank everyone for coming out on Sunday. I know it's been a busy conference and weekend, and excited to discuss melanoma updates. It's been a fantastic year for just developments for our patients with melanoma, and excited to share those with you today. So here's an outline of what we're going to run through. There's been several updates in frontline treatment for these patients. And then there's been new approvals and strategies in the adjuvant setting, in addition to a new FDA-approved treatment for patients with metastatic uveal melanoma. So first, just to discuss long-term data. So I love to show this slide. This data was presented a year ago at ASCO, but I think just shows how far we've come for our patients with metastatic melanoma. Used to be, 10 years ago, that patient with metastatic melanoma comes into your clinic. There's less than 5% chance that patient's going to be alive at 5 years. And this is a 6.5-year update for patients treated on the initial Checkmate 067 study, where patients got Ipi-Nivo versus Nivo versus Ipi. And at 6.5 years, almost 50% of patients treated with Ipi-Nivo were still alive. So I think this is just a testament to how far we've come, but also shows that we've still got 50% of patients that we need to keep coming up with better therapies for. So looking at triplet therapy, so for those patients with a BRAF mutation, there's been a number of different studies looking at what would be the benefit to treating a patient with PD-1, BRAF, and MEK inhibition in the front line. So IMspire 150 was a study looking at the initial triplet study, looking at patients that received vemurafenib and cobimetinib in addition to atezo versus just targeted therapy. So that triplet therapy versus targeted therapy. Based on the PFS benefit, this did earn an FDA approval, and so a triplet therapy is available in the frontline setting for those patients with metastatic melanoma. And additional follow-up presented at ASCO this year has showed persistent PFS benefit with this triplet therapy, have not seen an overall survival benefit at this time. This is an FDA-approved option. I get a lot of questions about which patients should receive this. I think for those patients with a BRAF mutation, maybe coming in, symptomatic disease, that you want to be aggressive but maybe wouldn't tolerate getting ipilimumab, this could be a good option for those patients. There's been several studies now looking at the other targeted therapy options. So this was Combi-I, so this was looking at dabrafenib, trametinib, and spartalizumab, so another anti-PD-1 versus dabrafenib, trametinib. Although very similar study, this study was not statistically significant, and so this regimen is not approved. Actually, very similar patient populations, I think a slight difference in statistical analysis. So I think this has led to some skepticism of what is the benefit for that triplet therapy up front for patients? Is that additional toxicity worth the benefit? And then the last triplet therapy that's undergoing evaluation is with encorafenib binimetinib. And so this was the initial phase 1 data looking at this triplet regimen. You can see patients with durable responses on the graph on the left and early deep responses on the graph on the right. And so this has led to the Starboard study that is open at Tennessee Oncology. And so this is looking at patients to receive the triplet therapy with pembrolizumab, encorafenib, and binimetinib. It's designed a little differently. This is comparing against single-agent pembrolizumab for frontline patients. So I think this will give us more data in that triplet setting, and then also look at just a different targeted therapy option for our patients. So for triplet therapy, what are the takeaways? There is an FDA-approved triplet regimen with atezo, vem-cobi. I think there may be a select patient population that can benefit from this. And there's an ongoing Starboard study looking at a randomized study with the last targeted therapy option to be evaluated. So exciting news in frontline therapy. We have our first frontline FDA approval in probably about the last 5 years with relatlimab, nivolumab. So this was based on Relativity 047. And so this looked at patients with metastatic melanoma in the frontline setting. Patients were randomized to relatlimab with Opdivo versus nivolumab in the frontline setting. So you can see here that there was almost a near doubling of patients' progression-free survival with the combination versus single agent. And you can see here still early for the overall survival analysis, but you can see those curves starting to separate. When they did a subgroup analysis looking at, okay, which patients might benefit from this regimen? Is it patients that have LAG-3 expression, PD-L1 expression? What about patients based on their BRAF mutation status or their stage? You can see here that the benefit was, trending towards all subgroups, so there really wasn't any distinguishing factor that might help us determine which patients would benefit from this disease. They did additional analyses just looking at LDH as a marker for disease volume and then BRAF mutation status, and all favored the combination. So another anti-LAG-3 monoclonal antibody, the fianlimab, was presented at ESMO this year. This is actually a study we participated in here at Tennessee Oncology. This was a phase 1 study looking at the combination of this LAG-3 monoclonal antibody with cemiplimab. And you can see here that 76% of patients were able to achieve a tumor reduction. And you can see the spider plot on the right, very early deep responses for these patients. So really excited to participate in this. Of the patients achieving a CR, one of those is a patient that lives here in Nashville that's been taken care of by one of my partners and a patient in our network in Chattanooga. So these are everyday patients we're taking care of out in the community, able to benefit from these treatments. And additional data for this combination. Now, this was a single-arm study, but you can see here the response rate was 62 to 65%. So really exciting data for this combination. So the takeaways for the anti-LAG-3 monoclonal antibodies, so relatlimab with nivolumab is now FDA approved. I get a lot of questions of which patients should receive this regimen. Although we don't have any indicators of exactly who's going to respond to this treatment, what I'll tell providers is, can that patient get ipi/nivo frontline? If you have any concerns, then I think relatlimab, Opdivo is a good option and really should be replacing when we used to give just anti-PD-1 monotherapy for any of the patients. So moving on to sequencing for patients with BRAF mutation. So another common question that we've had in practice but didn't have a good answer for was a patient that has a BRAF mutation, should I be starting with targeted therapy or should I be starting with combination immune therapy? And so DreamSeq was published or presented about a year ago and really helped answer this question. And so this was frontline BRAF mutant metastatic melanoma. Patients were randomized to either receive upfront ipi/nivo or dabrafenib trametinib, and then switch to the other treatment at progression. You can see the patients enrolled on this study, about 60% of patients had M1c disease, so that's a visceral disease. So these were patients with, in general, high burden of disease. Importantly, though, you can see prior treatment, about 12 to 17% of patients had received prior treatment. So what that means is this was predominantly enrolled in Europe. These patients were not patients that had progressed on prior anti-PD-1 in the adjuvant setting. And so what we saw with DreamSeq was looking at the progression-free survival. The benefit was definitely with starting with ipi/nivo. So you can see 11.8 versus 8.9 months. You can see here that at 2 years follow-up, we're continuing to see that PFS advantage with combination immune therapy up front versus the targeted therapy. What's important, though, to take away from this study was the early patients that had early death on study. So they looked at those patients that passed away within the first 10 months on the ipi/nivo arm, because you can see it was at 10 months that the benefit crossed and was seen with the immune therapy. And so for these patients that started on immune therapy but passed away early, they saw that the median overall survival for these patients was only 3 months. In general, these patients at PS1 for 42% of patients, most patients had an elevated LDH, and most patients had M1c disease. And these patients were on treatment for less than 6 weeks. And so the takeaway is that Although this demonstrated that ipi/nivo may be the preferred frontline agent for patients with the BRAF mutation, you really need to look at that patient in front of you. If this is a patient that's having worsening symptoms very quickly, you first met them and now they were ambulating in clinic, now they're coming in by wheelchair, that's a patient that needs targeted therapy because they may not get the chance in a second-line setting to receive that treatment. So I think it just goes to show that these are really important studies, but then you still have to look at that patient in front of you and make the best clinical decision. So takeaway from the DREAMseq, this was the first randomized study looking at these frontline standards of care. The takeaway that most patients should receive ipi/nivo, but early responses may matter for some patients, and so targeted therapy may be your initial first choice for some of these patients. Another study has looked at the sequencing of treatments, and so this looked at a different targeted therapy combination in the Sequomet study. So you can see the arm A was encorafenib binimetinib versus ipi/nivo, but this one had an arm C. And so these were patients that were initially treated with encorafenib binimetinib for 8 weeks, and then they were all switched over to ipi/nivo, which I think I do see in practice some, right? If you start with targeted therapy, you get that patient feeling better after that 8 weeks of treatment. Well, then can you switch to immune therapy? How does that compare? And so this tried to answer that question for us. So this slide has a lot of data, but what you can see here is arm A and arm B. Those were the ones initially evaluated on DREAMseq, very similar results. So you're seeing with time that PFS continues, the benefit continues to be with starting with ipi/nivo, but the patients that started with that 8 weeks of targeted therapy on arm C, we're seeing actually pretty similar PFS and pretty similar overall survival. So for the patients with a BRAF mutation, looking at sequencing, so frontline ipi/nivo, some patients may still benefit from upfront targeted therapy. And then this idea of the induction with targeted therapy, I think we're gonna have some more answers with an ongoing EORTC study looking at encorafenib binimetinib 12-week induction versus ipi/nivo. Those are the only 2 arms, and I think will give us more answers there. So frontline, looking at that patient, can they tolerate ipi/nivo? If not, I think your next option should be looking at relatlimab, nivolumab, and there's an evolving role of targeted therapy and triplet therapy for these patients. In the refractory setting, just briefly, to build on our discussion earlier, TIL, there was the first randomized study performed in Europe for patients looking at TIL in the second-line setting that did show a progression-free survival advantage. Overall survival still a little early. I think my one criticism is that it was compared to single-agent ipilimumab, which we know if you're going to give ipi, you should be giving it with anti-PD-1, but still interesting data to see. And then moving into neoadjuvant adjuvant, there's been a lot of updates here. So Keynote 716, this demonstrated a benefit for looking at pembrolizumab and giving pembrolizumab for those high-risk stage 2 patients. And so this was a study looking at patients with stage 2B/C, so patients just with a deep primary, did not have metastasis to a lymph node yet. This achieved an approval just about a year ago based on the recurrence-free survival. You can see that benefit of about 8 to 10% for those patients. And then just recently as SMR, we now have data looking at nivolumab in the adjuvant setting. So looking at the same patient population, you can see a pretty similar recurrence-free survival benefit. Importantly, they looked as well, where is that recurrence? Is it distant? Is it regionally? And you saw benefit in both places. So when you're talking to that patient with the high-risk stage 2 disease and they say, well, how is this gonna help me? Well, we're getting more answers to say this is hopefully gonna prevent both a lymph node recurrence or distant metastasis. And then another stage 4 adjuvant study. So this is a common question I get from practitioners. Hey, this patient isn't stage 3, it was actually a patient with stage 4 disease that incidentally had a lung nodule, picked up on a screening CT of the lung, and surprise, the biopsy came back as melanoma, or a patient with an isolated brain metastasis that you've either treated with radiation or resected. What should we do for those patients? And so Immuned looked at combination immune therapy, so ipi/nivo versus nivo versus ipi for these patients. And what we saw was a significant advantage to giving these patients combination immune therapy with Ipi-Nivo over Nivo and placebo. Now, it was designed to really compare to placebo, which we wouldn't give patients here in the U.S., but I think important to see that for these patients that had stage 4 disease, even if the primary tumor has been resected, still could be a benefit to giving Ipi-Nivo for those patients, but considering it in the adjuvant setting. And when they looked at breakdown by BRAF mutation status, and then even looking at overall survival, continued to see that benefit with the combination immune therapy. And then one last adjuvant study that was recently presented at ESMO, and you might have seen the headlines. Very simple study, but I think very impactful for our practice. So this was SWOG S1801. All they did was take patients, instead of giving them pembrolizumab all in the adjuvant setting, instead they moved up and gave 3 doses for these patients with resectable stage disease before surgery. And what you can see here is that there was a number of patients achieving a PR, CR, and there was a significant advantage to just doing those 3 doses up front. And so they presented data for the event-free survival, and you can see here the significant advantage to neoadjuvant versus adjuvant therapy, a little early for that overall survival. And so I do think this actually is probably practice changing at this point. So if you see a patient with resectable stage 3 disease in your clinic before they go to surgery, I think it's worthwhile to talk to that surgeon and that patient about, hey, should we start that immune therapy up front? Because there's likely a benefit to starting the immune therapy while there's still disease present before waiting and after resection. And then briefly looking at patients with uveal melanoma. I know it's a rare disease, but I feel like every practitioner probably is taking care of a patient here or there with uveal melanoma. And exciting news, we actually have an FDA approval for these patients. And so this is a bispecific, so tebentafusp. This attaches to CD3 on the lymphocytes and then GP100 on those melanoma cells. And so this was FDA approved based on a frontline study for patients with uveal melanoma. You can see at the bottom, these patients are randomized 2-to-1 to receive either tebentafusp or standard, quote unquote, investigator choice standard of care, because there really isn't a standard of care for these patients. And interestingly, so the response rates were less than 10% with tebentafusp. PFS was not impressive, but the overall survival benefit you can see here. And so that's ultimately what gained it an FDA approval. The challenge is, kind of going back to our cellular therapy discussion, so this patients, about 50% of patients have HLA-A0201 status, so that means it's only available for half of patients with metastatic uveal melanoma. It's weekly administration, and the first 3 doses, it's step-up dosing, and that has to be done. It's done in our clinic, and then those patients are admitted for 24 hours. So the way we've operationalized this at Tennessee Oncology, because it is a rare patient population, and realistically trying to train every clinic and hospital is a little challenging when you may not have a second patient that needs it. So what we're doing at Tennessee Oncology is, and that's been very successful, is those patients actually come, I see them, our staff has been trained, very familiar with the side effects. Those patients are it's administered in our clinic, they're hospitalized for those first 3 doses, and then they go back to their community clinic after they've really gotten through that initial toxicity period and are able to get it close to home. So I think an exciting option. The toxicities for these patients can be very real. We are watching for fever, chills, rigors for those patients, but also profound hypotension, hypoxemia. But once you get through those first couple of weeks, patients tolerate it well. Exciting that we've had this FDA approval, but we need more treatment options for these patients. And this is just additional data showing the response rates and the progression-free survival there. I'll take any questions at this point.
Dr. Rodriguez.
The neoadjuvant immunotherapy sounds very similar to what lung has done with the 3 doses of immune therapy. Why 3 doses? And what are we doing after in those patients?
Yeah, good question. I think this is really the tip of the iceberg for neoadjuvant therapy in melanoma. There's been prior studies demonstrating in smaller subsets showing that really giving PD-1 by itself is well tolerated, but the response rate isn't as high as we would like. Giving ipi-nivo neoadjuvant's too toxic, and some of those patients miss surgery. So I think this study just really showed three doses, I think, was just negotiated because those surgeons don't want to wait too long, right? They're saying, hey, I could go in and take this tumor out right now. These were resectable patients. And so I think it's really it was a time period that the med-oncs and the surgeons could agree, we'll go ahead and give this a shot. I don't think there is anything magical about those 3 doses in the conversations that I've had. So I think for a standard patient getting adjuvant therapy, I think, very attractive to give those 3 doses up front. But there was just recent data published looking at relatlimab and nivolumab in the neoadjuvant setting, and that looks even better, right? So I think there's definitely more to come, and the story's just getting written on neoadjuvant therapy for melanoma. But I think a good time to start those conversations with the surgeons you work with to say, hey, it's worthwhile for me to see these patients before surgery to evaluate if neoadjuvant therapy might be beneficial. Correct, yep, so they still get a year total therapy. You're just doing 3 of those doses before surgery.
So gaps in adjuvant use, particularly in the node negative. Do you think that there are people going untreated that should be going untreated? And how are we doing on precision medicine approaches, testing and follow-up testing after progression on BRAF inhibitors?
Yeah, great. So, I've been trying to get the word out about stage 2 approvals. I think everyone's known those stage 2B, 2C patients, they have a worse prognosis than 3A. So we know if you have just a couple cells in that lymph node versus a patient with a deep primary, you're actually better off. And so I've been trying to get the word out that to dermatology, to surgeons, that we need to see those patients. And essentially, any patient that has a diagnosis of melanoma, honestly, they should just go see med-onc. We're going to end up seeing a bunch of stage 1 patients, but I think as quickly as the field is evolving, dermatology, they can't keep up. So they need to rely on us to say which patients get immune therapy. So I do think there might be some patients that might be missing out yet. Some people will say, well, I still think that seems too early, and why are we treating so many patients with immune therapy? But really it comes back to those are patients with high-risk disease.
Are there additional value adds we can add to that population to make it more inducible? I think in breast cancer, we started seeing everyone once we added in AIs, tamoxifen. And then the chemotherapy, yes or no, was an additional question. Like, how else can we help that patient population? What else can we do?
Yeah, some of you have maybe seen patients that are coming in with the Castle Decision DX testing. I think it's still early on. We don't have prospective data to say a high-risk patient, should we be doing more intensive surveillance or not? It's really just retrospective data. But I think that's going to be, once there's more data there, I think we will be able to do more molecular profiling for these earlier patients to be able to say, hey, you are higher risk, or you are ctDNA positive, so you would be the patients that should get immune therapy. And then your other question about profiling. So I think obviously there's approvals in the stage 3 setting for patients with BRAF positive disease for targeted therapy. So a stage 3 patient should definitely have BRAF testing. Every patient with metastatic disease should have full profiling, not only to determine if there's a BRAF mutation, but to see any other mutations, NRAS, KIT. There's a number of clinical trials available for these patients. And then if you do the initial profiling at time of diagnosis, should you be repeating later on? It's a good question. We do end up seeing patients, especially like a BRAF mutation, they can develop resistance mutations and develop like an NRAS mutation that may make them a candidate for clinical trials down the road. It'd be rare for a patient to develop a BRAF mutation later, but it's generally more resistance mutations. So I think if it's a patient that's been on targeted therapy for a period of time or have been on a number of treatments, it's definitely worthwhile to repeat their testing. And another question I get about testing for melanoma, if you can do tissue, and oftentimes we're lucky because there's a lymph node or some other palpable mass that's easy to biopsy, I think the preference is still to do tissue, but if you can't, then you could potentially do blood.
Thank you. Anything else? Anyone else? Oh yeah, John.
At the end of the situation when a patient has a BRAF mutated melanoma and relapses in the CNS, let's
So for the virtual people, if you can repeat, so the question is for CNS metastases.
Yeah, so for a patient with a BRAF mutation with a brain metastasis, what's the preferred regimen? Is that a fair summary? So there's been data looking at dabrafenib, trametinib, and ipi/nivo for patients with brain metastases, had similar response rates for intracranial and systemic disease, but with longer term follow-up, it's durable with immune therapy. And so in my training, I worked with the authors on both of those publications, and even the authors on the publication for dabrafenib, trametinib would say, you should do ipi/nivo if you can for those patients, because we know with immune therapy, we're seeing durable responses versus patients with targeted therapy. They get an early initial response, but then are more likely to develop recurrent disease.
Perfect, thank you. All right, we're way over, but really appreciate your.
Great, thank you.
Mainly my question. Thank you, Meredith.